Hello everyone, I'm Samir Mhaysin, specialist orthodontist. I'm going to present this lecture titled Malocclusion Orthodontics and TMD. In 1987, a landmark court case entitled Prim versus Malloy in the USA promoted an in-depth examination on the issue of whether or not orthodontic treatment causes temporomandibular joint disorders. The Prim case resulted in $1 million judgment against a Michigan orthodontist for causing TMD in a 16-year-old girl. The orthodontic treatment involved the extraction of two maxillary first premolar teeth and the use of a headgear to address the patient's class 2 div 1 malocclusion. Temporomandibular joint disorders comprise a group of musculoskeletal and neuromuscular conditions that involve the TMJs, the masticatory muscles, and associated tissues. Dorkin in 1992 divided the TMDs to three groups. The first group was the muscle disorders, the second group disc displacement, and the third group other common joint disorders. The questions to be answered for this presentation were: is there association between malocclusion and TMD? Does the specific orthodontic treatment effectively reduce TMDs? Does the specific treatment cause TMDs? The first one who correlated between occlusion and TMDs was Costin in his paper in 1936. Dr. James Costin described a syndrome related to the temporomandibular joints and ears based on the analysis of 11 cases. The etiology was believed to be overclosure of the mandible due to loss of the dental vertical dimension subsequent to tooth loss. Ramfjord in 1961, in his study on 32 patients with pain, he found that the occlusal adjustment treatment is effective for TMD. And he found that the discrepancy between centrochelation and centric occlusion was the most common trigger for muscle spasm, bruxism, and dysfunctional temporomandibular joint disorders. Conti et al. 2003, a sample of two individuals. The individuals were divided into four groups according to the malocclusion and orthodontic treatment accomplished, but he lacked the control group. He found that there is no statistically significant association between TMD and the premolar extraction protocol non-extraction and upper, lower, or both arches extraction groups, and no statistically significant between TMD and headgear wearing, and found that there is statistically significant between bruxism, clenching, and tension and TMD. The TMD presence and severity was found statistically significant only for the absence of anterior guidance. The prevalence between males and females was statistically significant. Sonson et al. 2008 found that the grinding, the myofascial pain, the disc displacement, the tension type headache in the deep bite group more statistically significant than control group. His finding suggests that the patients with deep bite referred to orthodontic treatment, and in particular in subjects with a deep bite with retroclined upper incisors, these malocclusions can represent a risk factor for TMD. Giorgio Iodice et al. In his systematic review 2013 in regard to crossbite and disc displacement, 15 studies reported significant association between posterior crossbite and disc displacement, while 12 studies didn't find any significant association between posterior crossbite and disc displacement signs and symptoms. In regard to crossbite and masticatory muscle pain, 9 studies reported a significant association between posterior crossbite and masticatory muscle pain. 10 studies didn't find any significant association between posterior crossbite and masticatory muscle pain. In regard to crossbite and TMD, 9 studies reported significant association between posterior crossbite and TMD. 11 studies didn't find a significant association between crossbite and temporomandibular joint disorders. From a methodological point of view, the scientific quality of most part of studies analyzed in this review was medium to low, deeply influencing the importance and reliability of their relative results. Now, the relationship between orthodontics treatment and TMDs. Keeling in 1995, in his study, he assessed a robust number of participants. In this study, the participants were evaluated for TMD prior to treatment and then assessed by examiners. He found that the risk of TMD differs by orthodontic mechanics treatment techniques. Subjects with TMJ pain at baseline were 7 times more likely to have a pain at follow-up if they had been treated with a headgear bite plane or observed than if they had been treated with a pinator. Subjects with TMG sounds, TMJ pain, the muscle pain after treatment of 2 years of observation were more likely to be those who had the sign at baseline. In those subjects without a TMG sound, without muscle pain, and or without TMG capsular pain, there was no risk of developing these TMD signs immediately after early treatment with pionators and headgear bite planes. Early treatment with pionator and headgear bite planes didn't place healthy children without these signs at risk, only increasing age for development of sounds and failure to achieve a class 1 moral relationship placed sign-free children at greater risk. Fernandez Gonzalez, 2015. In his systematic review, none of the selected articles found a harm effect of the orthodontics treatment on the temporomandibular joint. 2 of them found that orthodontic treatment could reduce signs and symptoms of TMD. The majority of them showed a relationship between TMD and female sex and the fluctuation of its manifestation over time. The differences in TMD between those with and without malocclusion were small. Subjects with untreated crossbite, crowding, or large overjet showed a higher prevalence of signs and symptoms of TMD. And these are the included studies in his systematic review. Herr Nixon found that orthodontic treatment, either with or without extraction, didn't increase the prevalence or worsen pre-treatment TMD. Egar Mark, no occlusal factor is major importance for development of TMD, but the lateral force bite between RC and MI as well as unilateral crossbite may be a potential risk factor. Molen found that orthodontic treatment seems to be neither a major preventive nor significant cause of TMD. Leopold, early treatment of functional unilateral posterior crossbite in late deciduous and early mixed dentition significantly improved the treated patient occlusion. McFarlane et al. 2009 found that orthodontic treatment neither causes or nor prevents TMD. Borzocchi found that no statistically significant association could be established between TMD and the various factors under investigation, with the extraction of the association between gender and the Hill-Chemo index. Tikko found that the treated group showed improvement, although no resolution, in the signs and symptoms of MBS compared with the untreated control group. Abrahamson found that patients with dentofacial deformities corrected by orthodontic treatment in conjunction with orthognathic surgery seem to have a positive treatment outcome in respect of TMD pain. The home message: current evidence-based literature failed to demonstrate a relationship between various occlusal factors and TMD signs and symptoms. Orthodontics is generally described as a TMD neutral. It neither causes nor cures TMD. There is no evidence that early treatment, orthodontic treatment of patients with malocclusions will prevent the development of TMD in the future. The literature available on the matter suffers of medium to low scientific and methodological quality, independent of the association reported. Management of TMD is typically palliative and symptomatic. Thank you for everyone.